I'll move on. I think we're getting the picture, so I'll move through the other indicators that we're capturing here. Certainly a big one, again, is the vacancy turnaround time. How long is it taking providers to fill their beds? And Keith mentioned they're going to be implementing a 72-hour target for that. You can see we've got some that are close to that, some that are nowhere near, and this is just a tool that we can use to figure out where the outliers are and how to address them. And once again, we've got some trending information over here. How long, what's the turnaround time look today versus 6 months ago, and all the points in between.
As we set those 72-hour targets, will we be able to lay down a red line to show a target so that at a glance you can see who's over and who's under?
Yeah, absolutely. And I think when it comes time to roll this out to the information to the facilities, that'll be one of the things, a big red line on that 72-hour mark so that they can see, am I above, am I below, really black and white.
Can I just ask you though, you mentioned something, because I can see on the bar chart that the orange line is the turnaround time, and the blue dot is the number of admissions over the period of time. Can you just tell me a bit about what you were saying when you said if there's a low number of admissions but a high turnaround time, it's not as important?
Well, not that it's not as important. I think it gives some sense into, is this a systemic problem, or is there only one bed that's happened to be an outlier that sat there, kind of thing. So if, for example, if I see, Coquitlam happens to be really high, 20 days, well, was there just one bed that's accounting for that number, or is this a systemic problem that's happening every single time?
So I get that in terms of the average, but if, for example, you had a unit where you were only getting 4 admissions a month, but each of those was taking 20 days to turn around, surely that's a concern. Yeah, okay, that's fine. That was just to make clear for myself. Sorry, I got confused.
Yeah,
with that.
no, just you can look at the blue dots, got like a really low number, like Agnes's only got like two placements in the time frame and has got fairly rapid turnaround, but if it had a really long turnaround, then there may be a reason for that, right? Okay. The sample size isn't big enough to really indicate anything, right? With only 2 admissions, because it's a really small community.
But a deep bar with a high sample set says, I'm going to nail, if I focus on that, not that we'd nail it, but if I'm going to focus on that, I have a chance to make a real impact on this quickly.
That's right.
If they're blocked because they're renovating, or they had to paint a room, or that would show up in there too, though.
Probably after the phone call is made, to say, so why aren't you meeting your time frame? Like, just don't forget, right? This is representative of facilities that are 100 beds.
Yeah.
Right, and if there's a number of admits during the month, and we see the average, the turnaround is 5, 15, 20 days long. Something's going on, right? So, at the end of the day, it's about management. It's about giving us a tool to pick up the phone and say, I'm looking at this. So what's going on?
We've also encouraged the facilities to put the beds on delay if they're renovating, for example. So we've actually put renovations as a delay reason.
We would do ours. We don't put the bed on delay. We put it on internal. Because same kind of thing.
Subtracts that time, right?
Are these all the same types of beds? Are these all permanent beds, or are there some short stay beds in here too for respite? Because the turnaround on a unit that's got 10 short stay beds, there's a lot of factors that can impact on that too.
So I don't think these include our respite beds.
We don't have respite in
the very small number of beds. These are, for all intents and purposes, residential/complex care beds.
One of the other things on that note is in Fraser Health, we've only got pathways implemented for the residential care stream, or some other health authorities, like here in Calgary, for example, we've got several different care streams, and you can when you're looking at this data, you can specify which of those streams you're going to look at any given time, because, like you say, the numbers will be vastly different depending on. So,
David, we've got a question over there.
Yeah.
Oh, I just wanted to understand, are you hitting your production system, your production data, so it's in real time? And then you don't have any degradation in your systems for transactional use?
No, this is, like we said, it's updated very frequently, and it runs sort of independently of the regular Pathways database, so there's no impact in
So
terms
it's
of...
in a data warehouse data set?
Yeah, that kind of thing, yeah. One more question, Leah?
So your infectious disease outbreaks, is that internal or is that, how do you track that? Internal.
There's options within the system.
Yeah.
So different.
Anything else? We'll move on. Like the previous screen, we can drill down to the facility level again. So if I were to click on the Burnaby zone, for example, all my information is now showing at the individual facility level within Burnaby. So just like that's kind of consistent across the board.
So I would probably make my first phone call to the last one there.
86 is in trouble.
And keep in mind, like, they've never received a phone call on this yet, right? This is big stuff. This is part of the, when we put in the care model, this was a paradigm shift for them because it was about business. And we have our business is a $300 million enterprise, and so that became part of it. And now this is the next part of it. This is the feedback, the performance expectations, right? This is going to be new stuff for them.
So the next one is around vacancy volumes. So this is around the occupancy rate. You can see a chart or a listing on the right of all of the facilities and what their occupancy rate is. We're again at 98.8% in this particular area. And then just in terms of where the beds are. So we look at the historical vacancy data and we try to figure out, typically where are we finding that there's vacant beds, and that's where you see in the chart on the left.
Can I just ask, are you concerned about the two that have 100%? Are you concerned about the two facilities that have exactly 100% vacancy? Or sorry, occupancy.
Occupancy?
What's their number of beds?
So those are by communities, right? So those aren't sites?
No, those aren't sites. So that would just indicate that there was no discharges during that time.
Okay, that's fine. So it's not individual site, it's the entire community. Fine. Okay.
We can drill down to the site.
Like everything else, yeah, we can drill to the site level and get more details.
I just want to bring your attention, just that one number on the top right says 8. Remember I said at the beginning of the presentation we have 7,800 residential care beds? So when we did the snapshot, 8 was the number of unmatched vacancies in the system. Unmatched, 8 out of 7,800.
So we're really dealing with a tiny sliver of the big pie here. The source is the actual Pathways database. It's an operational database. So when the facilities have a vacancy, they're entering it into Pathways, and the Strata IQ product is just pulling that information and using it for this data.
So any difficulties with entering the data in a timely fashion?
Helen, you know any entry issues?
Yes, there is. Well, I mean, we have to rely on the facility to put the discharge in when the discharge occurs. Certainly, we sometimes run into problems, particularly over weekends, where Monday morning we have, discharges going in. I think the other problem that we have with some facilities is that somebody sits at pending accept for 3 or 4 days, but they're actually in the facility.
And we've had the same experience. It's just a matter of if the operator, somebody has to be clicking something and they may not have done it.
Yeah, so it's really getting,
That's right.
yeah, so it's really getting back to the facilities and saying, this really is affecting your stats.
But there's going to be financial consequences to not meeting some of these targets, right? So if they're a little lackadaisical in getting data into the system, and it's going to financially harm them, there's going to be an incentive to actually get into the system and make sure their data is correct. Because we will claw back money. If you are not at 98.5% of occupancy rate, we are going to take money back from you.
Does the facility have access to this too?
That's the game plan. That's our next steps I spoke about, is that they're going to get access to the system so they can see how they're doing, but not see other people's data. So that's a technical issue we're going to work on, but they have to be able to see their data in relation to others as well.
You have a question?
Well, I'm not sure if it's worth asking, but is there gaming that goes on, and does this help you uncover that? But I think you've identified that this will really diminish that because they have to get their occupancy targets.
There's other tools that we're using for the gaming aspect. So I've been somewhat concerned about some of the cherry picking that's been going on vis-a-vis the acuity of clients. So we have another data source that shows average length of stay, right? And so if I see somebody with an average length of stay that's well off the median, that's going to cause my people to do some questionings, what's going on, review the acuity, review the decline rates, and then bring in their executive director or the owner and say, it's not working for us.
And prior to this, you really have limited ability to do that kind of
We couldn't
analysis
do it.
and follow-up. Yeah.
Couldn't do it. That's the problem. We need a tool that quickly brought it up so we can take a look at, so our analysts can take a look at it, and then start to deal with the outliers at least first to say, we need to improve your performance. Yeah, we haven't talked about performance in the 7 or 8 years that we've been in existence as a health authority. Now we're talking about performance because we have a $300 million enterprise that we have to be accountable to.
Yeah, I think I would just add, because I come back to Ron's question, I thought it was a really good one for anyone that isn't a current user with Pathways. And I know if my gang would agree here, but to me, one of the things that encourages and entrenches providers putting in accurate data is the fact that we aren't triggering the data at the time a provider says, oh, I guess I better go in and configure this bed. We're using a discharge. So when someone passes or someone transfers at that facility, they operationalize a discharge out of pathways, and that can be sent on to anywhere else in the organization. But the fact that they're triggering that discharge, whether they decide not to do anything else or not, or forget, the fact is you have triggered that internal bed. And I'm not sure who was saying it, but one of my favorite intervals early on in a deployment is between establishing that discharge, which triggers an internal bed that will be available at some point. I may have to paint it, or I may have to have personal belongings removed. And when does that bed become available? That interval goes from this to this. And I think some of our folks would say that was one of the intervals that the low-hanging fruit came from. So we're not asking them necessarily to operationalize configuring their bed. But what we are saying is with a quick discharge, when someone passes, or, oh yeah, that's what I do when someone transfers, that is starting the clock ticking, which we are capturing and which can then be managed by folks like you. Does that make sense? Yeah.
Just in terms of, and I'm not saying that this will be a now issue, but certainly in the UK, when we are commissioning residential placements, we commission on a block contract. So we commission a number of beds from a facility. It seems to me that this is starting to give you the tools to move away from block and start to move into a tariff or a performance-based contractual arrangement. Is that right? And will you, is it your intention to grasp that nettle? Because I know the providers don't like that, because they cite things to us like, we can't plan our future income unless we know that the funding is available, et cetera, et cetera, et cetera. Yeah. And my answer to that is, I frankly don't care. It's down to you as the provider to provide us with the services that we can benchmark and say, this is what you gave us in real product, and that's what we'll pay for. Do you think you'll move down that road?
You know, I think in terms of our funding, I mean, I've heard the same argument. I just came back from Japan, and they have the same fights between their government officials and their owner-operator associations in terms of, we don't give us enough money to provide the care we need. Usually it's more about return on capital than it is about care. So, I mean, at the end of the day, we're still probably going to have contracts that say we're going to fund X number of beds, we're going to fund it at this particular rate for this particular year. We give them funding letters every year to adjust for funding. And then part of the performance expectation is these outcomes, which we've talked about today, one of being, for instance, the 90.5% occupancy rate. So when they don't meet those expectations, even though we have given them pre-funding in order to meet it, we will start to claw back those funds if you haven't met those targets.
And what happens if they exceed it?
Congratulations.
Okay, but not incentivized. So you're not incentivizing overperformance.
No, exactly.
Okay, that's fine.
The incentive
That's
is
fine.
to continue business with Fraser Health.
Okay, that's fine. Okay.
More importantly, as I mentioned at the beginning of my presentation, the number of our beds we have to increase is dramatic. 1,000 by 2014, and by 2025 we have to double the capacity we have today to meet the requirements as per today's ratio. That's a huge amount of money. So if you want to stay in good stead with us, do this work.